Now it is my pleasure to introduce the last speaker, Raoul Deo, coming from Boston, from the US. He did his medical degree in Cornell University Medical College, and then a PhD in molecular biophysics from the Rockefeller University. Then he completed his internship and residency at the Brigham and Women's Hospital in Boston. And then he did a fellowship at the Massachusetts General, also in Boston. He then conducted research in human genetics and computational biology at Harvard Medical School, and then at the University of California in San Francisco. His research interests involve bringing large-scale genetics and genomic data and computational approaches towards the goal of personalized diagnosis and therapy, which is actually the title of his talk. So please welcome Raoul.
I have some disclosures, and they're relevant to how I sort of have thought a little bit about this problem. So things will come up a little bit. So I'm going to talk about a little bit of a different topic than what's been discussed so far, but hopefully try to tie it back together again. So I'm going to talk about heterogeneity in disease and precision medicine. So before the recent AI hype, there was the precision medicine hype. Before the precision medicine hype, there was the personalized medicine hype. So we get a chance to sort of look at some of the sort of similar potential overselling and whether or not we made any progress. And so I'm going to sort of start even with this question that I think needs to be answered. Have there been any successes in precision medicine, and under what circumstances? And then I'm going to come back a little bit to this idea of computer vision and think about how we can bring automation to identify treatable yet sufficiently uncommon diseases that are under-recognized, which is something that physicians may not do all that well. And then one of the challenges with cardiology, unlike some of the other examples I'll give, is we don't have access to tissue very easily. So how do we build precision, sort of precisely defined disease subclasses in a situation where we just don't have any biological tissue? So I often start off a talks with this introduction. So I've been in the machine learning space for maybe about 10 years or so, and I sort of see those as being two main applications. One of them is largely operational and focused on replicating existing processes. And so some of this is just task shifting, trying to shift things that are potentially being done in a higher cost environment to one that could occur at lower cost with greater uniformity. We have the ability to sort of identify patients selectively. We can learn how to make decisions within an inpatient setting. And this is usually what I talk about, and this is what mostly people have talked about today. But today I get a chance to put my biological hat back on and think a little bit more about machine learning for a different purpose, which is redefining disease according to some idea of quantitative assessment of underlying biological processes. And so it's a little bit of a different talk than I usually give, but one that I'm excited to do. So what is this idea of disease heterogeneity? One of the sort of the frustrating things about medicine is that much of the way we've defined diseases hasn't really changed for potentially hundreds of years. I mean, we saw a slide today on diabetes, but really, I mean, diabetes probably is looked at not that differently from when it was originally defined as based on the sweetness of urine and its ability to attract ants. So we've learned a lot since in terms of underlying biology, but we're not really changing the way we define things according to these. And there's a question as to why. Why is it that we don't actually bring any of our biological insights underlying pathogenesis into our definitions? And the hope is that if we do so, we should be able to ideally match patient with treatment and facilitate development of treatments themselves. So this is a sort of figure I stole from the NCI, and they're sort of talking about this very reasonable idea that rather than thinking about cancers from an anatomic perspective, maybe we should be thinking about what are the drivers, and maybe there are drugs that could be targeted for drivers for different cancers in different anatomical locations, and yet still hit the same pathway. So it seems like a sensible thing to do. So one of the motivations for a lot of this is and it may not be a justified motivation, but it certainly is one that is talked about a lot, is this idea that the ability to develop drugs is still abysmal, and certainly the costs are enormous. And so our success rates going from a lead compound to successful phase 3 trials is still around 6% or so, and that really hasn't changed much. And many people have looked to point fingers as to why that may be, and some blame animal models for being poor surrogates of human disease, and others sort of bring up this idea that maybe we haven't defined our diseases well enough, and we're suffering for that because we have this mismatch between what is a fairly crude definition and what may be a very precise targeting. More generally, there's also this problem that if we look at the price tags of new drugs, which are also kind of astronomical, certainly in the US they're astronomical, there's a sense that this is unsustainable unless we have some ability to match drugs with patients in a more effective way so that we can find big responses. So this may all be a pipe dream, but certainly this is a motivation for thinking about how to overcome some of this heterogeneity. And so are there even any examples where things are successful? And usually the answer is yes in cancer. So in this case, I just show a slide describing, in this case, a tumor cell and a normal cell, and most commonly this would be breast cancer, which sees overexpression, at least in some individuals, only some individuals, of a gene and a protein called HER2, which is in the EGFR family, and it's important for the proliferation of and survival of these cells. So very sensibly, people have come up with the idea that one can target this and develop an antibody, but this only works in individuals, or works best in individuals who are positive for this receptor. So that makes sense. And so there's some precision there in terms of matching a drug with the disease. And in cancer, you see a lot of this. And so this is a slide for non-small cell lung cancer. And look at all, I mean, I'm jealous from a cardiologist perspective at this sort of exquisite matching of all of these different drugs that match very, very different protein targets. And part of that is because cancer inherently has access to tissue. So part of the diagnosis is getting access to tissue. And also these cells have a sort of an undue dependence on these pathways for survival, which is not really common for the rest of sort of the homeostatic system. So we do see these scenarios where we have absurdly beautiful targeting that are going on in a molecular way. And unfortunately, that works well when you already know what the answer is, but what about these situations where you don't know the answer and you just have a disease and you have some suspicion that it's heterogeneous? And this is where the sort of idea of machine learning comes back. And so people talked a little bit about unsupervised learning, and this is really an unsupervised learning problem. We have something that we think may be subdivided in some way according to some degree of homogeneity, and we don't know how to do it. So what people do in these cases is they collect a number of different features that describe these things, and they look for natural groupings. And there's lots of different algorithms one can do to do that. In this case, so this is a glioblastoma multiforme, so the disease we've heard about already today. And here they performed DNA methylation analysis, and they ended up having 8,000 probe sets that define these tumors, and then you can perform hierarchical clustering, and they give some sort of descriptors for these clusters. And so that's sort of an exercise one can do. But if you look at the sort of the incorporation of this has been going back since the early 2000s or so, and this really hasn't made its way into clinical practice. And there's a lot of sort of criticisms of it. So one of the criticisms has already been alluded to today by Bart, is this sort of idea of imposing this very, very hard classification. So the idea that the diseases, there are these non-overlapping clusters of diseases, and this doesn't really make a lot of biological sense. I mean, you'd think that there will be some underlying pathway activities that may vary from individual to individual, but the sort of idea of a classifier and saying, that you're group 1 and you're group 2 doesn't quite make a lot of biological sense. And these algorithms are really quite brittle in the sense that they're very sensitive to choice of features, and so these clusters can sort of fall apart. And so there are many studies that have shown that once you try to replicate them, and we'll talk about why that's even hard to do in the first place, you sort of find failures. And one of the issues here is that, and the machine learning people know this, is in very high dimensional space, the sort of idea of finding clusters is incredibly difficult. And so the idea that the distance between, let's say, two individuals who are the closest is actually not that different from two individuals that are the furthest apart in this high dimensional space. So that's the sort of the statistical criticisms. And there's also some criticisms from the biological side. And this actually sort of dovetails with a little bit of this idea of interpretability. So we can do these groupings, but we have no idea how to sort of look at the underlying pathways that are driving these groupings. We don't know how to turn this into any real biology. And it may very well be that we can do these groupings, but they have no difference whatsoever in terms of treatment responsiveness, so that's not great. And this is actually a real insidious issue that I've seen lots of times, is that the features people use are so expensive that the initial studies are heroic and yet still small, and nobody can replicate these things because nobody else will measure those things too. So we have problems with replication. We don't ever measure these in the context of any treatment trials because it's too expensive. So then we don't have any real rigorous way to look at whether these clusters have anything to do with responsiveness. And then you have to think about what kind of physician is going to be able to use an 8,000 feature model to be able to classify things, especially given that the technologies change. And so these have been real problems when it comes to trying to incorporate any of these things. And one real problem is also that these clinical trials are so expensive that they look for opportunities to limit expense, and so they'll be like, oh, sure, we'll do 100 patients we'll do with this DNA methylation array. So you're left with something that is just inadequate to be able to get at this. So I'm going to talk about our own efforts to try to build low-cost, highly informative features to overcome this problem. So that's cancer, and so is there any examples outside of cancer? And really there aren't that many. And there's one that is interesting. So this is out of a group at UCSF where I still have an appointment and where I was for 8 years or so. And what they did here was looking at a disease called asthma. And I think even at this point, everyone realized that there were different types of asthmatics out there. And so what they did is they actually took cells from the bronchial washing. So again, they have access to cells, unlike us cardiologists. And they did some gene expression microarrays, and they found a few different genes that sort of led to a high amount of differentiation in terms of subclasses. And these also made sense from a sort of biological basis based on something called the Th2 response. So this is a certain type of helper T cell that attracts eosinophils, and so it's a little bit of a different biology. And Genentech, when they developed a drug against this Th2 response, they saw very reasonably that if you stratify individuals according to serum levels of this gene called periostin, you found actually a very big difference in treatment response. But this is still difficult to imagine implementing. So now if you look at what's being done, people have made a much simpler type of method for stratification. So this is from the NICE guidelines for using a somewhat similar drug. And here all they're doing is looking at a cell count rather than any sort of fancy gene expression microarray to make anything. So my kind of contention is that probably if we can't kind of map these relatively complex classifiers into something that is simpler and easily measured and potentially biologically sort of sensible, we're going to have a hard time in terms of getting adoption. So that's it for those situations where one actually has access to tissue, one has access to cells, one has access to biology. So what do we do in cases where we don't? And so I'm thinking about our problems, which are the heart, but also our colleagues in neurology have this problem too, is that this is just not normally part of the diagnosis. The risk of a serious side effect or a consequence from a cardiac biopsy is about 1% or so. So you're not going to be doing tens of thousands of patients readily and just collecting this sort of tissue. And so we have to come up with ways to be able to still learn without having that access. And so I'm going to talk about two things here. One of them is a situation where the subclasses have already been identified. Somebody has already made some distinction in terms of some subgroup, but we still don't recognize these. And that's going to happen more and more so. The more and more precisely we start sort of defining things, we're going to be in a difficult situation where these are things that the typical kind of physician has not learned during training. So we're going to have a sort of an under-recognition problem that's going to be pervasive, especially if there's a therapy that ends up being relevant for that particular subclass. And then this problem that has come up already is this sort of idea that we haven't even identified the subclasses, and what are we supposed to do then? So this kind of idea of recognizing mimics of common disease is one where I think there is a room for machine learning approaches. And it is, I would say it falls under the decision support in the sense that it's just trying to standardize and elevate some degree of recognition for things that are otherwise being missed in almost a surveillance mode. And preferably you want to do this where there will be follow-up testing that can be more decisive and where there is a therapy or some benefit that comes from that recognition. And we've seen this, I mean, I see this at the centers I've practiced in, and certainly it's just anecdote, but there's a number of these diseases that just don't get picked up. The readers are busy, this is not on their minds, they may not have the appropriate kind of priors to be able to look for them in the first place, and so there are a number of diseases that just kind of come and go and just don't get recognized, and patients may get admitted again and again and again. And there's one in particular I've seen a number of times. And we practice at very, very specialized centers where we see much more of these than the typical community center. So there is sort of an opportunity that one could imagine doing this, but you have to think very carefully about what the test characteristics would need to be for this to be successful. So we are thinking about this in the context of echocardiography, potentially combined with ECG and other kind of characteristics from the EHR itself. And so Bart already showed this slide, but we built a system that tries to automate a lot of the basic aspects of echocardiography, ideally without any physician intervention. And so then we can imagine that once we have sort of some of this initial pre-processing done in this pipeline of taking a kind of a raw study and driving it through, we can start to think about those diseases that are being missed and potentially highlight these individuals. And so this is one example, this sort of idea of thickened hearts. And so thickened heart is a very crude sort of definition, but there's a number of diseases where you will find this to be the case. And so high blood pressure leads to thickening of the heart. You can also have valvular disease that leads to thickening the heart. And then there are these sort of less commonly seen diseases where you also see that. And sometimes the pattern is very different and very characteristic. And it's things that if you're sort of observant, you'll be able to pick up these differences. And they have different outcomes and different strategies that will happen based on this recognition. So we do have models for a few of these, and I don't think they are yet good enough to be deployed, but we're actually starting to push them even further. And so this is a disease that now has a therapy and is potentially thought to explain up to 15% of this heart failure with the preserved ejection fraction you've heard about a little bit already today. And there's medications, they could sometimes run in families. And so we have a model that automates this process. It still needs to get better. But the idea is there that this could be some element of decision support. We also have a similar model for another disease. And we have to be very careful because the priors are not going to be great in terms of these. So we have to definitely tune these algorithms and to choose a cut point where there is a sort of a nice balance between true positives and false positives, because otherwise you're going to irritate your provider. And so this is actually comes maybe to a slide that doesn't quite fit in with this talk, except that I think is actually very important. So on the same floor where I work, there is a program that is going on that is trying to build somewhat physician-less care programs for various diseases. And so one of these is cholesterol management. And they involve taking college graduates that we call navigators, and there's sort of quite good scaling in terms of navigators to patients. And these are individuals who have been within these prestigious hospitals that I work at, and have been horribly managed when it comes to cholesterol. And part of this is because the patients will push back and say, oh, I'm feeling some aches with such and such, and the provider just will give up and say, okay, that's fine. And so we have a number of individuals who are just not meeting any of the guidelines and goals that have been floating in the system for cholesterol, for blood pressure. And so we built a program that largely just took over this entirely. Didn't sort of say, hey, maybe you should try this. Just said, give me your patient and I will give them back to you in 3 months, perfectly managed. And the success rate, it is in the high 90%. The costs are way lower than the typical care that's going on. And part of the reason is it's just persistence. It's just sort of somebody who's there, who's able to get those labs done when they need to get done, get the interpretation, up-titrate the meds. It's just a lot of hand-holding. There's nothing sophisticated here from the machine learning standpoint, but it's something that fails. This is unreimbursed work within the current healthcare system, and it's things that physicians are being judged on now. So they're kind of happy because they're actually meeting their metrics finally. And so the reason I bring this up is only because I suspect that incorporating anything new will have to be done in thinking very carefully about what the existing care pathway is. And most likely anything you incorporate is going to be a burden on the provider and nobody's going to want it. So there's some sort of degree of ownership of the entire process if you want to be able to innovate, or you'll be left with, no, I don't want to log into this other program to see such and such thing that I don't even know what to do with after that. There is going to be that resistance. So we need to be conscious of that. All right, so the last thing I'm going to show is really this idea of situations where you can't have access to tissue, and yet you want to find underlying heterogeneity, and you don't really know how to do it. And so I'm going to show a couple of slides from heart failure with preserved ejection fraction, and then I'm going to talk about what we're doing at One Brave Idea. So this is a disease that explains about 50% of heart failure cases, highly heterogeneous. I mean, the name is just screaming heart failure with preserved ejection fraction, just screaming sort of a poor diagnosis in the first place. No genetic basis, pathways are different than infer, everyone's fighting over which animal models are actually relevant, and like I said, we don't really get tissue. So we did a little bit of work around this in terms of using, sorry, did this just die? Or just slow? Okay, sorry. So it is a disease that has not been successful in terms of any treatments that are out there. And I'll show you this TopCat trial I'll come back to in a moment. And so we took a bunch of, oh, it's just slow, okay. We took a bunch of clinical features from echocardiograms and clinical features. We performed Bayesian model-based clustering, fitting a mixture of Gaussians to this. And then we had some very nice differences in terms of survival curves. And then we went back to that TopCat trial, still had pretty nice differences in terms of survival curves. And now when we went, this was a failed trial, but when we look back at our group 1 here, we see actually pretty nice separation between treatment and placebo here too. But I think this whole thing has some problems. So one of them is that our classifier is really unwieldy. We have way too many features that have to go into them. They all have to be measured in some specialized way. So this is almost a kind of a deal breaker from the standpoint. And we have no way of mapping these back to any actual biology. So we have groups, but we don't know what they mean. We don't know what drives them. We have nothing that even sort of hints at what could be driving them in terms of differences. So I think this is a feature problem. I think we're working with features that aren't particularly useful. They're expensive to collect. They're often missing, and they're not very biological. So we want to build a method by which we can try to find biologically relevant features that can help these classification problems and help point to pathway abnormalities. And this has been, I think, very hard to do. So we're doing something a little bit interesting. So this is my dream, right? This is my dream, is to be able to find these sort of set of low-cost assays that can define, quantify, and track underlying disease biology in individual patients. And this is Plato's cave here. We want to be able to get at the essence of a disease rather than simply the superficial features. So we want them to be inexpensive. We want our models to be readily trainable. We want the features to be expressive enough to capture this complexity. We want them to ideally respond to treatment, and we want them to be interpretable so we can actually design therapies for them. And so we've done something a little unusual. We've taken a cytometry, so a based approach to being able to do this. So we want a low-cost and high-dimensional readout that is able to capture all kinds of different complexities in biology. So this is a weird thing we're doing. But it's been done deliberately to increase our sample size and yet still have high information content. So we're recruiting every day about 40 patients a day within cardiology clinics, general medicine clinics, and primary care. And we have very, very cheap assays. So this is like $3 per assay or so. And what we're doing is we're actually taking whole blood, and we're treating with a whole bunch of different perturbations that bring out some difference in the biology. And the perturbations we sort of understand in terms of what they do, but we're a little bit agnostic. We just want to see changes, and then we want to associate changes with disease. And we're recruiting about 1,000 patients a month, so we have the scale to be able to do that. And our assays cost around $5 or less in terms of all the processing costs. So we've recruited over just a couple, 3 months or so, we have about 3,000 patients. 1,600 of these have details on perturbations, and about 500 have now on 10 perturbations. And so these are the sort of things we're exposing them to. And you say, well, how do we choose these? It's really a little crude. What we do is we treat whole blood, various concentrations and exposures, and we look at sort of shifts in the scattering characteristics. These are all scatterograms. It should be 3-dimensional, but I'm just showing 2 dimensions here. And we want to see shifts that ultimately look different from what the vehicle control is, and then we want to associate with disease. So what we do is we generate a sort of a difference between the vehicle and the perturbation for every individual, and then we just build simple logistic regression models to try to see whether there's any information there relevant to disease. And we can do this, and the ideal thing is we can fail fast in startup kind of mentality because we have about 1,000 patients a month, so we can see whether there's any signal here. And so this is kind of neat. I mean, we have, with simply just a very simple blood signature, we have sort of classifiers that are pretty effective in terms of some of the existing common disease. And the goal is not to build classifiers. The goal is to expand phenotypic space in a way that we can start to identify subclasses rather than simply just find the things that are already known. But to do that, we need to have some confidence of signal. So this has been our approach. We are now in a position where we can sort of identify areas of this plot that are sort of strongly associated with current disease, and then we can start to think about mechanisms. So we can start to now drill down in terms of looking at genetic variation that underlies these changes. We can look at transcriptomic changes that underlie these changes, and we can sort of move from what I think are crudely defined diseases to a low-cost expansion of space to ultimately then apply machine learning to be able to reclassify these things. So that's it. So these are my conclusions. So I think that there are certainly examples where there is precision therapy out there, but they tend to be in places where there is access to tissue. And ideally, they tend to be in places where there's a simple mapping from the sort of the classifier to the target pathway to a drug. And more complex approaches just, even though they're done and they fill the literature, you still see many papers in high-profile journals doing this, they haven't been particularly successful in terms of adoption, or there's no adoption, and they haven't been able to even be evaluated for reproducibility because of cost, but certainly haven't been successful in that regard. And I think that this is not sustainable. We need to come up with sort of simpler features that can actually be tested. And so we are thinking definitely about this idea of using machine learning for automated disease recognition, and we expect that this is going to continue to be a challenge in the future. But for you to be able to get this adopted, you're going to need to be able to provide value to the patient, to the provider, the payer. Everybody has to sort of be on board. Otherwise, it's going to just be an impediment and a burden. And when tissue is not available, we need to find innovative strategies to be able to find these features that underlie these pathways. And so that's all. These are my current and past funding sources. And apologize for keeping you guys from lunch, but thank you for listening.
Thank you very much. I think it's very complementary to some of the other talks that have been, and something that I particularly like, which I partially tried to emphasize also, is that you say that you use the data that you have, even cheap new data, in order to try to find regions of patients where they go together based on similarities and so on. Because one of the things that you see also in the machine learning world or the medical machine learning world from the engineering side, is that there's a huge amount of work being done on the analysis of MRI images, for example, or CT images, but actually almost nobody gets these kind of investigations, and they're very, very, very expensive and not available at all. So the fact that we have to look at other data and ways in trying to understand this data, I think this is very, very crucial, and this is a thing that we really need to do. And we can discuss it further later this afternoon. Are there any pertinent questions? Otherwise, I think everybody's starting to be hungry. No, there is a question. Very good.
Sorry for keeping everyone. Just in Brussels, a plan that's being used for assessment of the pollution of the air and how it impacts health and people has been user-defined data sets. So people can input using reliable mechanisms that they can buy or make their own, and these data sets are actually more accurate than government-sponsored ones, at least in high-density population areas. Is there any feasible manner in which some similar method can be implemented health-wise, or not really?
Yeah, I think that's a great question, and I think that at the end of the day, it has to be what's the incentive for somebody to do that, and the challenge has always been if you're not giving anything back and you're just asking people to input things for you, which is what many companies are doing these days, you end up getting this very, very sort of biased group of individuals that are sort of selected to want to do that. And they often aren't the ones who have disease and have a lot on their mind. They often end up being sort of those recreational, quantified self type of people. So I think that we think about this also, and the way we think about this is that if you can do this in the context of some sort of care pathway or something where you're actually doing this and providing something, and then you're sort of recognizing there's an unmet need within that and trying to encourage the data to provide that, then there's better chance for being able to get that uptake. But even then, it still may be challenging. So I think it's a great point because there's so much information out there that is occurring. I mean, we're sort of being opportunistic around people who are coming in, but there's a lot of information that's being collected at home. And the question question is, how do you avoid the sort of selective biased missingness that will happen there? How do you avoid being this sort of burden on people where there's initially this great uptake and then after that it peters out very quickly? And I think this sort of incentives are really the challenging part, and we just need to think about sort of being a little bit clever about what are we offering in return.
Exactly. And one of the things there is the problem is with health data, of environmental data, you have the whole privacy issue, which is still absolutely unsolved, and we need to find solutions. Okay.
I think we can be back at 3. There will be so you can stay and ask questions to the panel. We'll be discussing all the questions, remaining questions, and the questions that Emilia was putting in her lecture. We invited Esther Paniagua, journalist, she will be moderating the whole panel, and you are all invited to join us. There is lunch, so you can have lunch in the Mensa of the university, which is just that direction. Very affordable menu, and we'll be back in an hour. Thank you.